Dr. Anshika Bensla, and she'll be speaking on exploring systemic inflammatory markers correlation with octa changes in diabetic macular edema. And I would request all speakers to maintain their time, please. So on to you.
Good morning, everyone. I am Dr. Anshika. I will be exploring systemic inflammatory and hematological markers correlation with microvascular changes in diabetic macular edema, and this was an OCT-based clinical study which was done in Guru Nanak Eye Center. Okay, so as we all know, diabetic macular edema is a leading cause of vision loss in diabetic retinopathy, and it is a process driven by hyperglycemia, inflammation, and VEGF elevation. It is also known through thrombotic conditions, but the mechanisms on how it influences microvascular changes remain unclear. So the microvascular changes that we measure on OCTA were macular vessel density, phase area, circularity, and perimeter. And systemic markers that were measured were neutrophil to lymphocyte ratio, mean platelet volume, platelet distribution width, interleukin 6, and serum ferritin. Various studies have been done in the past, but they were all OCT-based study, which correlated CMT and hyperreflective foci in OCT. So as we all know, these are very easily available inflammatory markers and known inflammatory markers. Our aims and objectives were to measure the systemic inflammatory and hematological markers in individuals with diabetic macular edema and to correlate these changes with OCTA findings. It was a cross-sectional study done over the duration of 1 year in treatment-naive NPDR patients with macular edema who were aged 40 to 70. After a detailed history of these patients were taken and other ocular diseases, other history of intraocular surgeries were ruled out, they underwent a general physical examination, and then after this, blood samples were drawn from these patients and sent for investigations to the lab on same day. Patient underwent an ocular examination and were classified according to ETDRS classification, followed by OCT, which was done to measure the CMT because our inclusion criteria was to include only the patients who had CMT more than 300 microns, followed by OCTA. And on OCTA, we measured the vessel density and FZ area, perimeter, and circularity. To assess the microvascular changes. These are the slides depicting how OCTA was done in various patients. So coming on to the results, so we had 30 DME patients. Out of these, severe NPDR were 60%, 36%, almost 36% were moderate, and 3% patient had mild NPDR. HbA1c was increased in 29 out of 30 patients, and macular VD was distorted and decreased in 93% of the patients. FZ area and perimeter were increased in 86%. And circularity was distorted in 63% of these patients. The systemic markers were as follows. Neutrophil to lymphocyte ratio, which is a known systemic inflammatory marker, was increased in 30 out of 30 patients. Mean platelet volume and platelet distribution width had similar results, increase in 22 and 21 patients. And serum ferritin and interleukin 6, interestingly, did not show an increase in majority of the patients. However, IL-6 was significantly increased in 14 out of 30 patients. So the correlation analysis were done. We did a quantitative analysis between NLR and macular VD, which showed a negative significant correlation with macular VD. And on a qualitative analysis, we can see that most of the patients who had a decreased macular VD had an increased mean platelet volume, and this relation was significant. Similarly, with platelet distribution width. With foveal avascular zone, we had a significant correlation with neutrophil to lymphocyte ratio and mean platelet volume. And FZ perimeter had a significant correlation, not a significant correlation, but it was still a positive correlation with neutrophil to lymphocyte ratio. However, the correlation with mean platelet volume was quite significant. With FZ circularity, so the circularity was distorted in most of the patients who had an increased platelet distribution width. So this is the gist of it. Neutrophil to lymphocyte ratio had a negative correlation with macular VD and a positive correlation with FZ area and perimeter. Mean platelet volume had a positive correlation with macular VD, FZ area and perimeter. Platelet distribution width had a positive correlation with macular VD and a reduced FZ circularity, that is fast circularity was distorted in patients with increased platelet distribution width. IL-6 and serum ferritin were not showing any statistically significant in our study. So systemic inflammation, we all know, is closely linked to diabetic retinopathy and eventually leads to fluid accumulation and diabetic macular edema by a blood retinal barrier breakdown. Neutrophils adhere to the cell wall, and this is reflected by a decrease in vessel density in the patient with increased neutrophil to lymphocyte ratio. The platelet function is altered in diabetes. It is a known prothrombotic state, as we all know, and because of increased beta thrombin, there is more vascular complication, which is reflected by increased MPV and PDW. In IL-6 and serum ferritin, there have been many studies that have shown that IL-6 and serum ferritin are significantly increased. However, we did not find any significant increase in serum ferritin. It was normal in 29 out of 30 patients, but IL-6 was increased in 14 patients, still significant, but our study did have its own limitations. It was a small study, and some oral hypoglycemic agents also have anti-inflammatory effects. Systemic inflammatory markers, they can be markers for ongoing microvascular injury and can serve for markers for monitoring diabetic macular edema and its progression in centers where OCTA is not easily available. Thank you.
Thank you so much. So my understanding is that you do these inflammatory markers in patients who already have diabetic retinopathy findings, or even with pre-diabetic retinopathy findings.
Ma'am, already diagnosed cases of diabetic retinopathy with clinically significant macular edema, because OCTA is not available everywhere. So the progression can just be monitored by using these markers.
Okay.
Whether it is progressing or not, because a microvascular level, we do not have OCTA and FA available in smaller centers.
And how, my question again to you is, how frequently do you monitor these markers, and how frequently do you call the patient for follow-up?
Ma'am, it can depend upon the stage of the diabetic retinopathy. In mild NPDR with no macular edema, we can just monitor them 6 monthly. And in patients who have clinically significant macular edema, we can monitor them 2 to 3 monthly based on the levels. If the levels are increased, then we can of course refer them to the higher center for further investigations.
Okay, thank you.